Hello, my name is Marc Tischkowitz. I'm a consultant in clinical genetics, and I'm one of the co-investigators on the CanRisk program. I'm going to talk to you over the next 5 minutes about genetic testing and multifactorial cancer risk prediction for breast cancer. We run the genetic service for the East Anglia region, and in our clinics, most of the work that we do relates to hereditary breast and ovarian cancer, as you can see in this slide here. We also have a fair portion of colorectal cancer cases. Some of the other cancers that we come across are things like renal and lymphoma, and a small portion of our workload is to do with rare cancer syndromes. So how to refer breast cancer patients with a hereditary component is really important as it makes our work more efficient. I'm just going to talk to you a bit about some of the basic principles behind hereditary breast cancer. And one of the core principles is what the testing actually involves. So genetic testing typically will involve a sample. It's usually a blood sample or a saliva sample. We can also use a buccal swab, and increasingly we use tumor, but we're often answering slightly different questions when we're doing tumor sequencing. There are two types of genetic tests in general. One of them is a diagnostic test, which is the same as a diagnostic test that you do in other areas of medicine. And this is really where we're finding a gene change, an alteration in someone who is affected with cancer. So we're trying to diagnose a hereditary predisposition in someone already affected. This used to be done exclusively by clinical genetics, but is increasingly being done by other specialists, such as an oncologist or a surgical specialist. Second type of test is called predictive or pre-symptomatic testing. And this is where there is a known mutation running in the family, and we are testing a healthy person, a healthy relative in the family, to see whether or not they've inherited that gene alteration. And this is really to do with risk stratification in terms of targeting who in the family is at increased risk of cancer and who might benefit from early detection or prevention. And this work is still very much carried out by the clinical genetics team and including genetic counselors. So as a rule of thumb, which families have an inherited risk? Well, age is an important factor. So typically, the younger a person with cancer, the higher the chance that there might be a genetic risk. Of course, some cancers are seen in certain age ranges, so this doesn't apply. But certainly for breast cancer, the younger a woman is when diagnosed with breast cancer, the more likely it is that you're going to find a gene alteration, you're going to find a hereditary cause. Another important factor is the number of people affected in the family. So the more people affected with breast cancer in a family, the higher the likelihood of finding a gene alteration. And also, particularly if these are close relatives, or if there are particular patterns. So often breast and ovarian cancer go together within the context of a BRCA1 or BRCA2 mutation. A brief overview of hereditary breast and ovarian cancer. By far and away, the most important genes are BRCA1 and BRCA2. They were originally identified in the 1990s, and they are still the most important genes. There's a high risk of breast and ovarian cancer for women from a young age. In BRCA1, you typically see more triple-negative breast cancer. BRCA2 is also associated with other cancers such as prostate cancer, breast cancer for men, and slightly increased risk of pancreatic cancer. Both of these are inherited in a dominant manner, which means that if a parent has one normal copy and one copy with the gene mutation, they have a 50-50 or 1 in 2 chance of passing on to each of their children, regardless of the sex of the parent or the sex of the child. These two genes account for less than 5% of all breast cancers, but a significant proportion of common epithelial ovarian cancer, so the serious type of ovarian cancer, up to 10% may be accounted for by mutations in these genes. And currently, the NICE CG164 criteria recommend a 10% chance of finding a mutation before we offer testing. And this is the sort of thing that can be calculated using the CanRisk algorithm. There are other genes that are linked to breast cancer in particular, and the ones highlighted there can all be, the probability of identifying one can all be calculated using CanRisk. The numbers on the far left are the average number of carriers that a GP surgery with 10,000 patients would expect to have. So you can see that for many of these are quite rare, but there are some like CHEK2 where you may have a reasonable number of carriers, although the risk actually associated with genes in CHEK2 is quite modest. I've also listed some of the very rare, more syndromic types of cause of breast cancer. And again, these would be very unusual to have one of these in the GP surgery, maybe 1 or 2 patients in a practice of 10,000. Often they have other clinical features that provide clues. But really the focus of CanRisk will be on this area here, on these genes, together with BRCA1 and BRCA2. So the value of identifying a mutation in the family, firstly, for the individual, if they're affected with cancer, then it may in fact impact on their treatment options. So they may require more aggressive surgery. You may do some preventative surgery, even if they've got cancer. So for example, if they've got cancer in one breast and that's being removed, you may then go on to do the contralateral risk-reducing mastectomy at the same time. If they've got more advanced disease, there are newer drugs like platinum and PARP inhibitors that may be relevant to them given their genetic status. And also in terms of cascading out to other family members, this is where it becomes important, because the genetic testing will target who else in the family is at risk, and therefore who else would benefit from either preventative measures or enhanced surveillance or early detection measures. And this is where polygenic risk can come into some extent, because it can be used to modify the risks that are associated with these genes, but it can also be used separately to look at risk at a personal level for each individual person. And again, CanRisk can give you the risks of cancer in mutation carriers, and you can then also add in the risk of cancer for polygenic risk scores, or you can do polygenic risk scores in isolation. So when is genetic testing appropriate? Well, it may provide an explanation for the diagnosis. So for example, if someone's got a breast cancer at a young age, this may explain the diagnosis. It can provide some information about prognosis, in particular the risk of developing a new primary in the future. It may have an impact on the treatment plan. It will aid risk assessment for relatives, and it enables predictive testing and appropriate screening in the rest of the family. On the downside, usually we require a living affected person. There are exceptions to that, but that is the ideal way of doing it. It does take some time, and it can create anxiety within a family. And surveillance can also be an issue. So for example, surveillance for ovarian cancer, it remains ineffective, it's unproven. So the only treatment that one can offer there is risk reducing surgery, so removal of the ovaries as a preventive measure. So in summary, I've given you a brief overview of BRCA1 and BRCA2 and also the other breast cancer genes. Important to remember paternal inheritance. Important to remember that genetics is only one component of the multifactorial risk assessment. And the overall goal here is to improve identification of at-risk individuals, so we can target early detection and surveillance to those people concerned. Thank you very much for your time.